நீங்க அங்க டேபிள் வச்சிருங்கம்மா, நான் வந்து பார்க்குறேன். இல்லை, இங்க வச்சிருங்க.
Hello. No, ma'am, 1:30. Trying to connect actually. I don't know, ma'am. Actually, நான் ஃபோன்ல கனெக்ட் ஆயிருக்கேன். ஆனா யாரும் தெரியலன்னு நினைக்கிறேன்.
வளர். Good morning. Good morning, all. Mithila, can you present the first case?
Good afternoon,
Dr.
ma'am.
Mithila?
Yes, ma'am. Yes,
Good
ma'am.
afternoon, ma'am. Will you be ready for the first case? Anyway, we'll start. The meeting starts only at 2 o'clock. So, can you present the first case, ma?
Sure, ma'am. Okay, ma'am.
Yes, ma'am. Ma'am, good afternoon, ma'am. Valarmati, ma'am. Eil, ma'am. Good afternoon, ma'am. Ma'am, நீங்க உங்க ஆடியோ கேட்கல.
குட் ஆஃப்டர்நூன் வளர்மதி.
மேடம் சாப்பிட்டீங்களா?
சாப்பிட்டாச்சு, ரெடியா இருக்கோம்.
ரெடியா இருக்கீங்களா? அப்ப நீங்க செகண்ட் கேஸ் பண்ணிட்டீங்களா?
ஓ எஸ், வை நாட்.
சரி மேடம். உங்களது எல்லாம் ரெடியா இருக்கு மேடம். எவ்ரிதிங் will be done மேடம்.
ஓகே, தேங்க் யூ.
Thank you மேடம். Thanks for your infectious enthusiasm. சரி.
உங்களாலதான் நீங்க எல்லாம் பண்றத பார்த்து நான் பண்றேன், அவ்வளவுதான்.
ஓகே மேடம், ஓகே மேடம். Thank you மேடம். ஸ்ரீஹர்ல இருந்து இது மெட்ராஸ் மெடிக்கல் காலேஜ்ல இருந்து சுமிதா. சுமிதா are you there? கண்ணம்மா கண்ணம்மா உட்காருங்கடா. எம்எம்சி பிஜி யாராவது ஆடியோ.
ஆமா, எம்எம்சி கேஸ் கூட இன்ட்ரெஸ்டிங் கேஸ்.
போன் பண்ணோம் இப்போ. பாப்பாத்தி மேடம் அது ஜிவிஎம்ஸ்ல கவர்மெண்ட் வெல்யூ கிடைக்குது. மேடம் பாப்பாத்தி மேடம் குட் ஆஃப்டர்நூன் மேடம்.
Good afternoon.
மேடம் பெஸ்ட் விஷஸ் மேடம் அண்ட் கங்க்ராச்சுலேஷன்ஸ். போட்டோஸ் எல்லாம் சூப்பரா இருந்துச்சு.
Thank you so much.
So we are so proud the dean is joining our respected dean is joining our city path meet. Madam?
Oh, laptop. Oh, thank you so much.
மேடம் வீடியோல வாங்க பார்க்கலாம் உங்கள.
அதான் ஸ்டாப்ல வந்து கனெக்ட் ஆக லேப்டாப் கொண்டு வந்துட்டு இருக்காங்க. அதுலதான் இது வந்து இந்த டெஸ்க்டாப்ல கேமரா இல்ல, அதனால
ஓகே மேடம். சரி வந்துட்டோனே you can come in மேடம்.
லேப்டாப் வந்தோனே நான் இங்க வரேன்.
ஓகே மேடம்.
Thank you so much.
Congrats, Banu. Banu,
Thank you, ma'am.
congrats.
Ma'am, thank you, ma'am. Thank you, ma'am.
ப்ளீஸ் ஆன் பண்ணு. நம்ம நல்லா தானே இருக்கிறோம். ஆன் பண்ணிட்டோம்.
Wow, super.
வாட் பிளஸ் யாரு இது யாரு போட்டுட்டோம்.
வீடியோல வர மாட்டேங்கிறாங்க. யார் முகம் எல்லாம் பார்க்கலாம்னு பார்த்தா
எல்லாம் இருக்காங்க, எங்க டிபார்ட்மெண்ட் இருக்கு. ஆமா.
என் மைக்ரோஃபோன் நான் மியூட் பண்ணணும்னு பார்க்குறேன், பார்க்க முடியல. வளர்,
மேடம் சொல்லுங்க மேடம்.
என்னோட மைக்ரோஃபோன் மியூட் பண்ணணும்னு பார்க்குறேன், முடியலையே.
எதுக்கு இப்போ மியூட் பண்ணோம்? இருக்கட்டும் மேடம், unless there is any noise. தேவைன்னா போட்டியாடா? ஐயோ போடி. ஓகே. Court meeting is about, CPAC meeting is about to begin. All people are in kindly one to guest station. PGs வர சொல்லுங்கப்பா. ஹலோ மேடமா, PGs வர சொல்லுங்க. It's a program. Chandrika அவ பேர சொல்லுங்க. கிருத்திகா, PGs எல்லாரும் வர சொல்லுங்க. All PGs, whoever is எல்லா PGs வர சொல்லுங்க. Enjoy, relax. Okay, don't get tensed. ஹெட்செட் எல்லாமே ஸ்கிரீன்ல வந்து ஸ்கிரீன் ஷேர் ஸ்கிரீன் ஷேர் இப்போ இல்லடா எங்க ஐயோ யாரு என்ன ஏஜ் என்ன இது நானே இப்போ காமி அவளுக்கு ஆனா தர்ஷனா நினைக்கிறேன் ஆக்சுவலி இதுல கம்மியா இருக்கு. நான் இப்ப எந்த இன்ஸ்டியூட் என்ன ஏஜ் எந்த ஸ்டேட் ஆஃப் ஸ்பெல்லிங் இருக்கும் என்ன சாப்பாடு கொடுங்க.
Hello, Valar.
மேடம்.
Good afternoon. Can you hear Dr. Sandhya?
எஸ் மேம், குட் ஆஃப்டர்நூன் மேம்.
Good afternoon. Good afternoon. How are you?
How are you ma'am?
I can see some elite crowd there. Yeah, good. So anyway, we're once again very happy to be a part of the city to family meet. I think we should one physical meet.
Yes ma'am. நீங்க டிசைட் பண்ணி பிளான் பண்ணி சொல்லுங்க மேடம். We should have one. This is the 39th. இன்னும் 11 weeks வந்தா 50th ஆயிடும்.
Oh my God, really superb.
So நீங்க even we can 50th காக நம்ம வெயிட் பண்ண வேண்டாம். We can do one meet.
Sure. We can decide. We'll take it.
Dean of Weber Medical College has joined. Welcome, madam.
Wow, Dr. Papati.
Yeah.
Enga madam enga?
வீடியோல இருக்காங்க.
I can see her in all her splendor.
Ma'am, Ellie ma'am, thank you ma'am.
And Dr. Elil madam, madam is also there. Oh,
Sandhya.
Elil madam. Hello, madam.
How are you?
I'm fine. I'm reporting here, so I'm not putting the video on. So I'm
Oh,
kind of
Okay.
there.
I'm just waiting for the meeting. அதனாலதான் போட்டேன். யாரையும் பார்க்க முடியல.
Madam, it's an honor the dean is joining our meeting. Madam, say something, say some words. நீங்க தான் சொல்லணும். பாப்பாத்தி madam.
I'm so happy to be here
Thank you,
because
madam.
city pathology team knows that has given me a platform for presenting all the pediatric pathology cases. You remember the 22, 23 from ICH, we are the one presented so many cases. And
கண்டிப்பா
I
madam.
got the appreciation award from Ganesan sir. Really, அது எல்லாமே வந்து that help us to move further and for motivate the youngsters also. So at the age of 50, I have learned the molecular pathology and established a cytogenetic lab and started flow cytometry, immunohistochemistry, and so many things with the support of this city pathologist help. Especially Krishna Kumar sir, he helped me a lot while establishing this molecular lab. We personally visited his place, and he has given so many suggestions and advices to us that helped us a lot. Then I thank Dr. Srinivas, and he only identified me and encouraged me to present hemoglobinometry thalassemia cases in our city pathology forum. So thank you so much, sir. And my heartfelt thanks to all my teachers from my guru, Dr. Gopati madam. அவங்க இல்லைன்னா நான் இல்லை. Because of her only I have that interest in pathology. Then I thank all my professors, AVS madam. AVS madamனால தான் நான் வந்து இந்த pediatric pathology, அதாவது pathologyல தனித்தனி இதுல போகணும், that advice given by her only. So I thank AVS madam, and she helped me and guided me in establishing the lab. Initially, we have faced so many hurdles. So my heartfelt thanks to Shanti madam, Karkulali madam, Nagaratna madam, Eli madam.
Stanley.
For all the directors, Subbalakshmi ma'am. So I think I should not take so much of time I should not steal, so much of time from you. So thank you so much.
Ma'am, thank you so much, ma'am. Thank you, sir, for that kind words. Thank you. You were there presenting. ஞாபகம் இருக்கு நீங்க presenter present பண்ணிட்டு இருப்பேன். And congratulations and best wishes on your retirement, madam. Madam is retiring this month. Madam, இங்க சசிகலா இருக்காங்க நம்மளோட. She is also
Hi, Sashikala. Thank you.
Madam, good afternoon to all the professors and all the faculties, all the PGs, ma'am. Congratulations and happy retired life, ma'am. Papa
Thank you. Thank you so much.
All the best for all the presenters.
Ma'am, shall we go on to the ma'am? நீங்க உங்க comments கண்டிப்பா வேணும் as usual, பாப்பாத்தி madam. Ma'am, shall we go on to the first case, madam? The first case will be presented by Dr. Nithila from Srihar. Dr. Nithila, please share your screen.
Yes, ma'am. Sure, ma'am.
Anyway, YouTubeல இருக்கும்.
And is the screen visible, ma'am?
Connect பண்ணுமா?
Screen. Yeah, your screen is visible.
Sure, ma'am.
Yeah.
Okay, ma'am. So, good afternoon, everyone. This is Dr. Mithila, senior resident from Sri Ramchandra Medical College.
Yeah.
So the case I'm going to be presenting is actually proved to be a wing of mystery We'll find out why. So it was a case of a 23-year-old female who presented with complaints of pain on movement of the right eye and visual disturbances for the past 2 months, and protrusion of right eye for 1 month. The pain was associated with retroorbital headache, which was of dull, aching type, and it was exacerbated on movement of the eyes. It was also associated with multiple episodes of vomiting. There was history of numbness over the right side of the face, the eyelid, the forehead, as well as the maxillary region. However, there was no history of seizures or sensorium or limb weakness, and no significant family history was also noted in this case. On physical examination, protrusion of the right eyeball was present. There was painful restriction of extraocular movements of the right eye, and sensory impairment in the ophthalmic and maxillary segments of the right trigeminal nerve distribution was noted. However, no involvement of the facial nerve was present. A relative afferent pupillary defect of the right eye was noted. Visual field defects of the right eye was also noted. No other limb weakness was present. The radiological investigations which were done outside showed on CT, we observed a hypodense mass lesion in the right sphenoid wing with heterogeneous contrast enhancement and erosion of the right greater wing of sphenoid. MRI brain was proceeded, and it also showed a contrast enhancing lesion measuring about 3.3 centimeters in the greatest dimension in the right sphenoid wing region, and it was seen extending into the orbit. So the clinicians made a diagnosis of right sphenoid wing lesion with orbital apex syndrome and A-wing sarcoma. Right extended pteronial craniotomy with lateral orbitotomy and zygomaticotomy was done with maximal safe resection of the extradural soft tissue, space occupying lesion. We received 2 specimens grossly, which was sent as tumor tissue post-op. Specimens A, we received both specimens. We noticed multiple gray brown soft tissue fragments, and we all embedded the lesions. And one slide, we did squash cytology, where we saw a few nests and a few sheets of cells. And these cells were round to polygonal, which had elongated moderate amount of cytoplasm and around 2 elongated nuclei with the moderate amount of nuclear pleomorphism was also noted. In the frozen section, we saw in the background of fibrocollagenous tissue, few embedded bony trabecular fragments were noted, as well as few nests of cells which showed sort of a round cell morphology. So finally, we gave it as a positive for neoplasm, suggesting a round cell collections with necrosis. And we proceeded for further histopathological evaluation. So the sections predominantly showed fibrocollagenous background with few bony trabecular fragments and areas of tumor tissue and necrosis. So here we are able to see bony trabecular fragments and a fragment of the tumor tissue. And also
some background noises there.
Kindly switch off your audio, please.
Okay. So we were also able to see a micropapillary pattern of the tumor as well. And here we are able to see a cribriforming as well as some areas of glandular pattern noted with dirty kind of tumor necrosis also noted. This was characteristic glandular pattern of the tumor cells. And many tumor cell nests were cribriforming as well. The individual tumor cells were round to polygonal with moderate amount of cytoplasm and moderate to marked nuclear pleomorphism with a lot of mitosis, with few atypical mitotic figures were also noted. And prominent nucleoli was also noted in many of the cells. Also, extensive areas of tumor cell necrosis was also noted. So we were stuck at a point where there was just this lesion in the sphenoid wing, but it showed tumor cells which showed predominantly a glandular micropapillary and cribriforming pattern. So given the age that it's a 23-year-old female, we thought of the possibilities of sinonasal carcinoma, which could be of adenocarcinomatous intestinal type of adenocarcinoma, as well as a remote possibility of adenoid cystic carcinoma, or sometimes a possibility of salivary gland malignancy like adenoid cystic carcinoma, and the remote possibility of a metastasis from a colorectal carcinoma or lung or prostate or bladder. Predominantly lung or breast might be the possibility. So we proceeded to do IHC. Pan-CK showed nice, strong positivity, cytoplasmic positivity of all the epithelial malignant tumor cells. SAT-B2 also showed nuclear positivity. And CDX2 was also positive. So nuclear positivity was seen. So CDX2 positivity ruled out the possibility of a mucinous bronchoalveolar carcinoma, which was one of our DDs in mind before the IHC. CK20 was also positive in few of the malignant tumor cells. This is quite less sensitive for poorly differentiated colorectal carcinomas, if at all we thought of that. But this rules out primary lung malignancies or anal carcinomas or adrenal cortical or prostatic carcinomas. So CD117 showed variable positivity. CD30 was done, so this ruled out any lymphoma possibilities. CK7 turned out to be negative. P63 was also negative. So with the IHC report and the histopathological report, we were zeroing on two diagnoses. One, the possibility of a metastatic deposit from lower GIT, but this we were skeptical to give because of the age. The patient was just 23 years old. The major point here to note is that there was no lower GI malignancy symptoms on the patient. The patient just presented with orbital or ocular symptoms only. Or it could be still a sinonasal malignancy with intestinal features of adenocarcinomatous type, directly extension or perineural extension into the sphenoid wing. Meanwhile, while we did IHC, we suggested PET-CT to be done to the patient. So the clinician, after we gave the diagnosis, proceeded with PET-CT, post-op radiological investigations. So post-op CT brain showed no significant residual mass or tumor bleed. Post-op 18 FTG PET-CT scan was done, and this showed a malignant looking near circumferential wall thickening in the superior and middle rectum with foci of periserosal infiltration, and this was quite above the proximal to the anal verge. And also multiple FTG avid lesions, mass lesions, about subcentimetric lesions noted in the liver as well. And also multiple sclerotic lesions were seen in the cervical, thoracic, as well as the proximal femoral shaft areas, suggestive of bony mets. And also in the lung, multiple tiny nodules, again subcentimetric, was seen in the bilateral lungs as well, likely metastatic. And apart from this, there were a lot of mesorectal lymphadenopathy was also noted. In the middle cranial fossa, an ill-defined FDG avid residual mass lesion was noted post this craniotomy. So final impression was given that there was multiple liver, lung, bone mets as with residual extraaxial intracranial metastasis involving the right middle cranial fossa. But this could be from a superior and middle rectal lesion that also had mesorectal lymphadenopathy. So we zeroed in on one diagnosis of a colorectal malignancy, but still the patient had three things we had to actually consider. The patient didn't have any family history of cancers. Neither did the patient present with any symptoms relating to the GI lesion. And also there was no syndromic association. Even if we consider HNPCC, the patient had rectal involvement and not any right-sided mass lesion. So this was a very rare case of an sphenoid wing metastasis or skull-based metastasis in a very young age. So coming to the discussion, this is the posterior and the superior views of the sphenoid bone. So The sphenoid bone basically has a greater wing, which has an orbital surface, temporal as well as the cerebral surface. So this foramen rotundum actually is the conduit for the ophthalmic branch of the trigeminal nerve. So our patient actually had numbness over the forehead and the eyelid region. So probably the mass might have been compressing the foramen rotundum structure, passing through that. This was taken from the Handbook of Clinical Neurology, and they gave a list of malignant lesions involving the greater wing of sphenoid, which could be ranging from sarcoma, lymphoma, plasmacytoma, and metastasis as well. But predominantly, in their studies in compiling literature review, most of the cases actually showed metastasis from breast, lung, prostate, and direct extensions from the head and neck lesions as well. So either through direct extension or foraminal widening, that is perineudal spread also. But our case actually showed mets from the colorectal region. Coming to skull-based metastasis, it is one of the least common tumors to affect, least common, distant metastasis is actually very uncommon in this region. It occurs in about 4% of all the patients with cancer, but predominantly, even if it occurs, it might be due to prostate, breast, or lung being the primaries. The patient also had orbital syndrome in our case. That was the clinical diagnosis as well. So here, if at all it involves the orbital bone, the patient might present with a frontal headache and progressive dull pain, which was the presentation in our case as well, along with numbness and proptosis and sensory loss in the distribution of the ophthalmic branch of the trigeminal nerve, which was characteristically seen in this case as well. In Pinato et al., the study was done in 2015, and there was a case involving the sphenoid wing as well, and it was a manifestation of the metastatic colorectal cancer. But in this case, they noticed the colorectal cancer diagnosis 1 month before the infiltration of the sphenoid wing. Here, in this study, they say that the metastatic lesions affecting the greater wing can be described on the basis of the number of lesions. So in our case, it was a single lesion. Osseous extension, here it did not spread across the sutures. Extraosseous extension, ours involved the orbital cavity as well as the middle cranial fossa, and the nature of the lesion, ours was a lytic lesion. So this case report was actually the first one reported of a sphenoid wing metastasis from a colorectal cancer. So orbital metastasis, actually the time between the development of the primary tumor to the metastasis is actually very long. Most commonly, it's from the carcinomas of the breast and the bronchial system and prostate. So treatment actually predominantly involves adjuvant chemotherapy and radiotherapy. However, in our case, surgery was done, pterional craniotomy, because they didn't consider the possibility of a malignancy, let alone a metastasis. In a study by Nabil et al., they studied the literature, and they proved that most of the cases actually from the rectum, most of the cancers from the rectum actually metastasized to the metastasized. Okay, so the tumor emboli here, one school of thought was that the tumor emboli through the middle and inferior hemorrhoidal veins spread to the inferior vena cava, and via the pulmonary circulation reached the carotid arteries and involved the ophthalmic artery. Here, they found that pulmonary metastasis through this route was more common. Another school of thought was that rectal cancer spread through the Batson's venous plexus, involving the cranial venous sinus, and finally the ophthalmic vein. Here, vertebral metastasis was observed. In our case, vertebral mets as well as pulmonary mets and hepatic mets was also noted. So in review of literature, Kajwa et al. Showed that studied literature where in among 8 patients, 7 had a known history of colorectal cancer. Only 1 they were diagnosed after the initial presentation with visual disturbances. And most of the cases actually the mean age was 50 years, but in our case, the initial presentation was ocular symptoms, and the age was also very young, 23-year-old female. And predominantly the survival was overall survival on an average was just 10 months. So this was a case of a radiosensitive orbital metastasis presenting with an occult colorectal adenocarcinoma. So in this case, they actually noted his history of benign polyp only on colonoscopy. And here also they noticed multiple metastatic lesions. And the patient actually received only radiotherapy. So this was a literature review by this Ludmer et al. And most of the cases actually had a known history of cancer. This was the first reported case of bilateral vision loss is the first presentation of colorectal adenocarcinoma. And they did mutational studies as well. Here, most commonly, the mutations involving KRAS and BRAF mutations were more aggressive, as well as APC and TP53 were the most aggressive ones that were actually metastasizing. So our case right now, the patient, it was just received 2 weeks back. So when we spoke to the clinicians, their plan was to actually give adjuvant therapy for the primary rectal lesion. And apparently the patient improved very well after the surgery was performed. The visual disturbances, the movement of the eye all improved, and there was improvement in the vision as well. So to summarize, we actually need a multidisciplinary approach, and MRI and PET-CT's importance is actually there for us to further evaluate our cases. And if any patient presents with headache and ocular symptoms, we might need to dig a little deeper and be aware of the symptoms, and it could and think in terms of a metastatic lesion as well, irrespective of his age. And family history should be considered, but in our case, again, family history was not at all significant. And pathologically speaking, mutational analysis is a must to find out which mutations actually have more likely metastasis to be occurring. I thank my reporting pathologist and Dr. Sandhya Sundaram ma'am and our HOD Dr. Leena ma'am and all of the faculty who helped me. Thank you so much.
Thank you, Dr. Mithila.
Thank you, ma'am.
Have any questions, ma'am?
No, I was thinking of first I saw the histopathology. I was thinking in terms of a ductal adenocarcinoma of the lacrimal gland, but PET scan shows a different story altogether.
Yeah. Yes, KK. Actually, we were also very confused. Even 1% we didn't think it was from the colon because the patient had absolutely no colonic symptoms. So for us, it was an absolute surprise when they did the PET. So we directed the PET. We said, you have to do it. And this was a real surprise. Our department, Dr. Archana and Dr. Lawrence, when they saw, Dr. Archana was saying that I believe sphenoid ring is a common site for metastasis. And that was a learning that we got from this case. I believe that is a site for metastasis from rest of the, malignancies elsewhere. So I think it was very shocking for a 23-year-old female. As very rightly Mithila said, age does not matter. Nothing matters. Even the symptoms nowadays are, kind of so abstract that we have to keep and we as pathologists, we see it all together. So it really, I think we need as much information as possible.
I think PET scan has, I think, revolutionized everything, doctors. PET scan is.
So that's what, but we had to direct it because the patient never came with it. She came only with that orbital. So they didn't even think of, why would you want to do it when the symptoms are not localizing to that? So only when we direct.
Dr. Sanjay, it is no protocol in the, I think the Julius Scott and all these people, any orbital malignancy, we have to do a PET scan to call it primary, before we exclude lesions elsewhere. That's a protocol now followed by the tumor board, usually in Chandra, Julius Scott, all those people.
But it was not like a traditional malignancy. It was so glandular. So we had so we were not thinking of any primary malignancy that site. So we had to kind of direct the PET scans. Yeah. Thank you. Thank you.
Ocular symptoms was there, ma'am?
Yeah, yes, Balan.
Ocular symptoms, exophthalmos, what were the symptoms, ma'am?
Headache. She only complained, isn't it, Mithila? What was the primary complaint?
Pain
Yeah.
on
Headache
movement of
and
the
this
eyes,
kind of
headache, and proptosis. These were the major ones, ma'am.
that was nothing. Even afterwards, later when we checked, no GI. Very surprising. I don't know how it was possible that she had so many lesions, and this was what she came with.
Yeah, it is a very surprising case and very nice approach and eye-opening for a lesion in the. We always go by the textbook thing. Now we are deviate to think many other factors also. Sandhya Sundaram
Yes, madam. Yes, madam. You're right.
presentation.
Yes,
The hard work to come to a prompt diagnosis.
absolutely. Exactly, madam. Exactly. It's a lot of thinking process, lot of
Yes.
putting it together goes into it. So it's like
And
that.
nowadays we get more cases confusing to come to a known primary or becomes like known primary without the marker diagnosis very
Is
difficult.
important. Absolutely. It's mandatory, madam. It's mandatory.
Yes,
And
yes.
new entities have also come. See, we were thinking since it was all localized, we're thinking some, sinus carcinoma, sinonasal with intestinal type. So many things come into the differentials nowadays with increasing type of malignancies that are reported. So
I too thought of sinonasal intestinal type, but
yeah,
unexpectedly
this is a
coming
surprise.
to
It's a
diagnosis.
very, very big surprise for us. Absolutely. Thank you, madam. Thank you.
Thank you, madam. Thank you, Dr. Mithilan. Thank you, Sandhya, madam, for that extraordinary case.
Thank
Can
you,
we go
ma'am.
on to the next presenter, Dr. Krishna Kumar? Sir, please.
Madam, today we got a lab meeting. NABL auditing is going on. So
Okay, sir.
thanks for
You are capable of multitasking. Yes,
No,
sir.
yes, doctor, I'll do it fast.
Yes,
So
sir.
we got a potpourri of slides.
Yes, sir.
Good morning and good afternoon to all my seniors and my friends. The first case is from Chennai Skin Foundation. Hypo patches on the chest. So scraping was done. They had, so we see the filaments and the yeast-like structures. This we call spaghetti and meatballs. This is a classical case of tinea versicolor. Routinely they do because sometimes we don't want to miss some other hypopatches which can mimic tinea versicolor. Then this is Dr. Subha's case, a dermatologist. This patient had fever and with some joint pain. And they sent the video that this tender plaques came on the extremities. She had fever and she had mild arthralgia. So they were thinking in terms of whether it is drug erection or leprosy reaction. So biopsy was done. And in the biopsy, we find epidermis. There is no basal cell damage. We find dermal edema. And there is a lot of neutrophils, eosinophils, and lymphocytes, and some. So with this, we gave a diagnosis of Sweet syndrome, and the patient responded well to steroids, and she was referred to hematologist, and other parameters are all normal. So this was a neutrophilic dermatosis of Sweet. It was not a leprosy reaction. Patient is doing well. Third is case from Bangalore. He had for past 10 years, 10 to 15 years, multiple pustule eruptions and extensively itching, and they were responding to steroid therapy. So these are the images sent by the patient. Multiple pustules on the scalp, on the neck, on the beard area, on the ear. See these annular lesions around the below the eyelid. HIV was negative. And so this is the biopsy shows a dermal inflammation. We find inflammatory pathology involving the sebaceous glands and the hair follicles with the neutrophils and eosinophils. And there are lymphocytes and plasma cells. So it was a pandermal inflammation. So we thought of a possibility of an eosinophilic pustular folliculitis. And so this was finally signed out as eosinophilic pustular folliculitis. And the patient is responded to colchicine. Eosinophilic pustular folliculitis, it could be usually seen in the Japanese population with intense itching. And surprisingly, we also see this entity here. Third possibility is from Aravind Eye Foundation. Lady having lupus. And for the past 5 years, she had this lid lesion, which whenever she removes it, it comes back again. So biopsy was done by Dr. Vikas Menon and Joy of Aravind Eye Hospital. And you find here epidermis and dermis, and you find a focal thickening of the basement membrane. PA stain shows positivity of the basement membrane. suggesting it is discoid lupus erythematosus. We find perivascular and periadnexal infiltrate, but focally we find the squamoid looking cells with keratinization, and the infiltrate was very, very deep. And once again, this was area of concern for me. So what I thought was, are we looking at a discoid lupus erythematosus with atypical squamous cells going in for a possibly squamous cell carcinoma? So the patient please saw on hydroxychloroquine from last week. What I understand is, if within 2 months, if the lesions does not regress completely, the dermatologist is asked to remove the mass completely, because there are around 4% of discoid lupus erythematosus in the sun-exposed areas can turn into squamous cell carcinomas. Then this was from Radhakrishnan and his wife's dermatologist Nirupama, scalp lesion in a boy and a yellowish papillomatous lesion. Sample was sent for opinion. You find verrucous epidermal hyperplasia, and you find abortive hair follicles and basaloid cells. And what was interesting is you find these apocrine sweat glands. So with these apocrine sweat glands, and these are normal occurring sweat glands, made a diagnosis of sebaceous nevus. Sebaceous nevus, I think a common tumor is trichoblastomas, very rare possibility of BCC and sebaceous carcinomas. But this is sebaceous nevus, and Dr. Radhakrishnan assured me that he has completely removed the mass. Next is from Sundaram Medical Foundation. Girl, 25 years, having atrophic patches. She's on insulin injections. They thought whether it is scleroderma. See, this pigmented patches, atrophic, and there was hypertrichosis in these thigh areas and leg areas. So once again, these sort of areas were seen in the leg. The parents are very much concerned. And biopsy shows epidermis and dermis. We find a combination of fibrosis and inflammatory cells, with inflammation and fibrosis extending into the subcutaneous fat. This was a paniculitis. You find this foamy macrophages and myxoid-looking cells. Once again, to show that the myxoid-looking cells, plasma cells were seen. So we thought of whether I am looking at a paniculitis. And so these are the possibilities I give. Lipodystrophy syndrome. Could it be an insulin site reaction? Last possibility is H syndrome. In H syndrome, which happens in type 1 diabetes, we see these sort of skin changes and atrophic changes and lipodermatofibrosis. But we need to do this mutation for SCL2983. Finally, it turned out to be H syndrome, because I understand the lady had hyperpigmentation, hypertrichosis, scleroderma, hepatomegaly. So H syndrome is commonly seen in type 1 diabetes. We pathologists must be aware of this entity. Then this is from Chennai Skin Foundation. Thought astenia vesicular by outside, not responding. So it was referred to Dr. Muruk Sundaram. Biopsy was done. And you find this bizarre looking cells. You see this, coilocytic changes and all these things. So this was a case of epidermodysplasia versiformis. So EDV is a primary EDV, genetic condition. That's the reason in the first case they did scraping. See this? You're looking at it, dermatologists will think this is tinea vesicular, but it did not respond to the antifungal therapy, and biopsy was done. It showed epidermodysplasia versiformis. And this is the last case, annular plaques in the face, biopsy on multiple lesions. This is leprosy, and biopsy shows you find macrophages and giant cells, and acid fast bacillus is positive. So this was a case of mid-borderline leprosy. So this is what we have in dermatopathology. I was not able to show my skin eye pathology slide because of the auditing. Any doubt, please let me know, doctor. I'm glad to clarify.
Sir, thank you, sir. That was, you presented some 8 cases, a potpourri of 8 cases, sir. Sir, அப்புறம் ஆஃப்டால் வரதா எப்படி சார் இதுவே சார்? It was very good, sir. From sweet syndrome, and that head syndrome was new, sir. And the mutation.
Apuram tinea versicolor, then epidermodysplasia versiformis, head syndrome, sweet syndrome, eosinophilic pustular folliculitis.
So head syndrome, how often do you come across, sir? Head syndrome, how often do you come across, sir?
Doctor, இதெல்லாமே ரெஃபர் டாக்டர். நான் வந்து இப்போ இது வரைக்கும் ஒரு 4 கேஸ் பார்த்திருக்கேன் டாக்டர். கோயம்புத்தூர்லேருந்து கேசஸ் வந்திருக்கு. There is one இதயங்கள் ஃபவுண்டேஷன், டாக்டர் கிருஷ்ணன் சுவாமிநாதன் runs a type 1 diabetic foundation. ஸோ ஒரு 600 சில்ட்ரன் வந்து அவங்க பாத்துக்கிறாங்க. ஸோ அந்த கிரௌட்ல இருந்து நிறைய ஹெட் சிண்ட்ரோம் நான் பார்த்திருக்கேன். டாக்டர் சர்வேஸ்வரி ஃப்ரம் சுந்தரம் மெடிக்கல் ஃபவுண்டேஷன்ல அவங்க பாக்குறாங்க. ஒரு 2 பார்த்திருக்கேன், ஒரு 4 கேஸ் பார்த்திருக்கேன் டாக்டர். Many times they clinically diagnosed, doctor. They don't do much because we don't have much treatment for these kids.
Sir, those histopath findings were very non-specific, illa sir, for head
ஆமா டாக்டர்,
syndrome.
இட்ஸ் ஒன்லி கிளினிக்கல் கோரிலேஷன் டாக்டர். ஹிஸ்டோபத்தாலஜி பார்த்தாச்சுன்னா நம்ம பானிக்ரேட்டிஸ் தான் சொல்ல முடியும். பட் ஒன்ஸ் தே டெல் இந்த மாதிரி பிக்மெண்டேஷன் இருக்கு, ஹேர் இருக்கு, டைப் 1 டயபெட்டிஸ்னா then only we can think of head syndrome. இல்லாட்டினா டிஃபிகல்ட் டாக்டர்.
எப்படி கேக்கே பயங்கரம் பயங்கர கேஸ் வெரி நைஸ். I'm just appreciating you, KK. I was telling my PGs you are my co-PG. That's what. Yeah.
மேடம் நான் இன்னைக்கு ஆடிட்டிங்
எப்படி பயங்கரமா இருக்கு வேற லெவல்ல இருக்கு KK.
டாக்டர் பின்னிட்டு இருக்காங்க எங்களை. நான் அப்படியே நான் உத்தரவு வாங்கிக்கிறேன் டாக்டர்.
Okay, sir. Okay, sir. Thank you so much. Thank you so much.
I learned something new. H syndrome. Yes.
Head syndrome. Okay. Yeah. Dr. Mithil, Dr. Sumita, are you ready?
என்ன போடுறேன்னோட
Ma'am, everybody, ma'am, if you're ready, you can share your.
I'm ready. You have
Yes,
to
ma'am.
do
Yes,
that.
ma'am. I will do it, ma'am.
From the WhatsApp or from the mail, it is easy.
Yes, ma'am. Yes, ma'am. Getting ready, ma'am. Just
Okay.
a minute, please. Ma'am, is that madam's first picture? Ma'am, yes, ma'am. Your screen.
Thank
Welcome,
you.
ma'am.
Yeah. Second. This actually, I wanted to present this case for the interest of confusing with other normal we can see in other parts of the body. But since it is present in the cutaneous lesion, I wanted to give it for the PGs and assistants or whoever it is. And in our case, a 38 female, left malar region, there was a soft, slow growing, painless nodule. And histopathology, the cut surface appears little whitish, solid, and gelatinous. Next slide. Yeah. This is a histopathology images. Can you appreciate the description? The well circumscribed but unencapsulated, more of dermal lesion with a chondroid and focus, some myoepithelial cells with the glandular structures surrounded by 2 cell layer, and numerous plasmacytoid cells were seen. Next slide. So I thought we are dealing with a case of a cutaneous mixed tumor of the skin, that is chondroid syringoma, and phenomenon, it can be called as an apocrine mixed tumor, ecrine mixed tumor, benign mixed tumor of the skin, and chondroid syringoma. Next slide. So the previous one. Okay. So as I've described, when you see the well-developed lesion, epithelial and myoepithelial cells. The previous slide.
Okay.
Here the description of the slide, when you see them in the bland appearing epithelial and myoepithelial cells forming a gland, duct or cyst, in a reticulate or a lace-like pattern arranged in nests with a biphasic component, more of epithelial with two-cell layer and outer layer with a columnar or cuboidal epithelium. And some of the cells showed decapitation secretion was made out in our section, but there was no squamous metaplasia in our session. Next. Yeah. So with the discussion, when you see a amount of mesenchymal and the sweat gland component, you have to think in terms of a benign adnexal tumor, and morphologically the identical to pleomorphic adenoma. That is why I put a mimic there. And benign mixed tumor of the salivary gland. And most mixed tumors have both eccrine and apocrine components, and they are currently classified as eccrine type, and benign tumor of sweat glands with myxoid stroma and cartilaginous metaplasia. Next slide. Here, some of the cases, or even in the same slide, we might appreciate an apocrine, follicular, and sebaceous differentiation. But when you see a presence of any follicular or sebaceous features, rules out a pure eccrine mixed tumor. And occasional cases may have neoplastic tubules connecting directly to normal follicular infundibulum, and follicular differentiation may be seen as a common type of differentiation. And metaplastic myoepithelial cells include, it can be clear cell chain, collagenous spherules, hyaline cells, plasmacytoid cells, and twin cells. In our case, the metaplastic myoepithelial cells were seen predominantly in a plasmacytoid cells in a background of mucoid background or a myxoid background. Next slide. So the differential diagnosis, we have to think cutaneous chondroma, which will lack the epithelial and myoepithelial component. And malignant mixed tumor of the malignant chondrocyringoma, there will be necrosis, infiltrative growth, and marked pleomorphism and greater cellularity. Metastatic carcinomas, you can differentiate by IHC and cytological features of malignancy. Paracarcinoma, which is very rare, there will not be no true ducts, actin will be negative, and presence of physalliferous cells, you can come to a conclusion. And arises adjacent to tendon extremities, these tumors are more common. Now we can call it as a variant of myoepithelioma. And myoepithelioma or adenomyoepithelium of the skin, which is always commonly seen in the extremities lesion, negative for cytokeratin and CEA. In our case, it was more in the head and neck region. Next slide. When you think features of malignant transformation, you have to accept severe increased cellularity, mitosis, and destruction of the surrounding tissue and tumor necrosis, which is not seen in our case. It's a benign soft tissue or a cystic lesion. Next case. Next slide. Next slide. Before going to this molecular abnormality, the cytology also, when you do an FNAC in these cases, we can see many epithelial cells with bland nuclear and chondromyxoid background. That will always incites the diagnosis of a fixed tumor of the skin, and sometimes you can see a case with a nuclear pleomorphism, a nucleoli with the features of a malignancy in a case of a cytology preparation. But predominant features will be a fibrillary chondromyxoid background, cellular component of epithelial myoepithelial cells, and absence of ATPs. And positive strains, you can take IHC is generally not required, but inner epithelial layer, you can put keratin, EMA, CEA, and GCDEP 15, actin, cytokeratin 15. Other myoepithelial layer component or stromal component, S100, SOX10, NSC, GFAP, SMA, calpanin, P63. A variable positivity with SMA and GFAP, and P53 positivity of varying its intensity. Next come to PLAG1 nuclear expression in apocrine mixed tumors. And negative stains, Desmond and P16 will be negative, which is a strong, in contrast to strong nuclear positivity in malignant chondroid syringoma. So coming to molecular abnormalities seen in the chondroid syringoma for the molecular level of diagnosis, PLAG1 rearrangement is more commonly seen, and rarely you can appreciate EWSRI1 rearrangement. Next slide. This is what is commonly seen, I have told you, PLAG1 rearrangement, although which is characteristically seen in pleomorphic adenoma of salivary gland, or not seen in, that is the fusion, PLAG1 or HMGA2 fusion is seen in pleomorphic adenoma of salivary gland, which is not seen in chondroid syringoma, where only the rearrangement has been detected in subset of cutaneous mixed tumors. And nuclear immunochemical expression of PLAG1 is also seen. And subset I told you already, EWSRI1 rearrangement. Next slide. So then I think the audience will read my diagnosis. Anyone have any problem?
No, ma'am. Thank you, ma'am. Thank you for that nice case.
Yeah, mixed tumor of the skin, we generally, commonly, we don't report that chondroid syringoma, very rarely we have seen. And the presentation is a very typical presentation, head and neck region, the left malar region, soft, slow growing nodule of soft nature. And consistency, it was quite little gritty, and that cartilage softness was there in the cut surface. They were sent as a cyst, but we knew it is going to be modified in the diagnosis.
So it's a cutaneous pleomorphic adenoma. Madam. Yes, ma'am.
But we don't call it as pleomorphic adenoma, we call it chondroid syringoma.
The benign lesion and just excision window.
Yes. But now without the marker, they are able to do it.
Yes, ma'am.
Yeah.
Thank you, ma'am. If there are any questions,
many students have done study in these chondroid syringoma. There they have done the molecular arrangement and another marker study to confirm their number of cases. In our study, HND was the main diagnostic modality of diagnosis.
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. If there are no questions, then we can go on to the next case, ma'am.
Thank you.
Yes, ma'am. Thank you so much. Thank you so much for that nice case. Dr. Divya from Stanley Medical College, ma'am. She'll present the next case. தெரியாது நீங்க எங்க இப்படி
Good afternoon. I'm Dr. Divya, Assistant Professor at Stanley. Before starting, I would like to thank my HOD, Dr. Nalli Sumitra ma'am, for giving me this opportunity to present in the forum, and special thanks to Dr. Valarvati ma'am for her guidance. So, a 16-year-old male presented to the OPD with complaints of swelling in the left lower back for a month, and the onset was insidious and it progressed. The size progressed and there was dull aching pain over the swelling, which was intermittent in nature. So, on examination, a 5 x 5 centimeter swelling was observed in the left lumbar region, which was hemispherical in shape and form and consistency and not mobile. A USG was done and a swelling of 4.6 cross 4.5 cross 3.5 was seen in the intramuscular plane with solid and cystic components, and it was reported as degenerated intramuscular tumor. After the USG, an FNAC was done and the smears were cellular it was arranged in papillary configuration and also in sheets and also singly scattered. The cells were round to ovoid with scanty cytoplasm and dense chromatin. So the impression of malignant small round cell tumor was given. An MRI was done after the FNA and a swelling of 5.3 cross 4.4 cross 4 centimeter was identified in the left back at L2 and L3 level, and a possibility of soft tissue sarcoma was given. So PET scan showed uptake, heterogeneously enhancing irregular soft tissue mass of 8.4 cross 7.4 cross 6.7 centimeter in the subcutaneous plane in the left posterior abdominal wall. So here we can see the uptake. Then a true cut biopsy of the left lower back swelling was done. Here we can see sheets of neoplastic cells, which are prominently arranged around in the form of perivascular aggregates, and there are areas of necrosis also seen. So in this high power, we can see round to ovoid cells with dense chromatin and scanty cytoplasm. Here we can see brisk mitotic activity. We can see brisk mitotic activity and areas of necrosis were also seen. So with this histopathological image morphology, with the small round blue cell tumor in mind, we have put the IHC CD99, which turned out to be diffusely membranous positive. Then we did other markers, CD45, which was negative, and it ruled out lymphoma. So other markers done were chromogranin, synaptophysin, which turned out to be negative and ruled out other tumors like neuroblastoma. Desmin and myogenin ruled out rhabdomyosarcoma. And again, the neuroendocrine marker and Desmin ruled out desmoplastic small round blue cell tumor. And negativity of CD117 and CD34 ruled out undifferentiated blast cells. So with the morphology and the IHC and FLI1, which was done elsewhere, turned out to be positive, and NKX.2 also done outside elsewhere was negative. So with all this, with the morphology, with the IHC, we have given it as extraskeletal Ewing sarcoma, and we advise genetic study. Bone marrow biopsy was sent and it was negative for malignancy, and 4 cycles of chemo was given to the patient, but there was no response. The size of the tumor remained the same, and so next we received an excision. FISH was done. FISH for EWSR1 gene rearrangement turned out to be negative, and so we received the resection specimen. So we received a skin-covered soft tissue mass, which was multinodular, and it was fleshy, gray-white to gray tan, and areas of necrosis were also seen. So here we can see diffuse sheets of small round cells, round to ovoid cells. Here again, round to ovoid cells with scanty cytoplasm and coarse chromatin. Few of them show prominent nucleoli. So these were the extensive areas of necrosis seen. So when IHC was done, CD99 turned out to be positive. WT1 showed positivity and TLE1 showed positivity. So the positive tumors were CD99, WT1, TLE1, and K67 was 95%. The negative markers were CD45, desmin, myogenin, CD34, CD117, PAN-CK, synaptophysin, cyclin D1, and EMA. So with the morphology and with CD99 positivity along with WT1 and TLE1 positivity, we have given the impression with two differentials. One as CIC Dukes 4 rearranged sarcoma and two as a poorly differentiated synovial sarcoma. And we have advised genetic molecular workup. The patient had taken the sample for genetic workup. So here, the CIC rearranged sarcoma comes under the undifferentiated small round cell sarcomas in the recent WHO edition. So here, the age group, both of them are almost young adults. Both have a slight male predominance. Both tumors are common in the trunk and the extremity. So IHC, we have CD99 positive to be in both, and WT1 positivity in CAC rearranged sarcoma, which is mostly Dukes 4, and in TLE1 positivity in synovial sarcoma. So the cytogenetics, the gene involved is translocation 419 and 1019, and here in synovial we have X18. So molecular alterations are CIC Dukes 4 rearrangement, and here SYT, SSX and SXX2 or SSX4. So in both the cases, the prognosis is poor.
Yes, ma'am. Sorry, can I see? Just want to see more on the video. Okay, good. Yes, ma'am. Any questions?
I thought it is a evenings in the slide which open.
Yes, ma'am. Yes, it was small round cell tumor, but then EWSR1 and all that was negative, no, ma'am.
The fish done was negative, ma'am.
Mm.
And there's
So,
no response and treatment for done for Ewing.
mhm.
And they started treatment for Ewing's. The patient did not respond, madam. The swelling grew further bigger for the 16-year-old child.
Yeah. But the lesion, site of the lesion lower back, will it?
Yes, ma'am. A 16-year-old male, lower back.
That is also very rare as extraskeletal leavings we can think. But no other poorly differentiated synovial sarcoma.
Because that TLE1 was positive, ma'am, here.
With the morphology and IHC, ma'am. And it also CD99 was positive.
Yeah, but synovial sarcoma, I think, can present in many patterns.
Yes, ma'am.
Synovial sarcoma, I think we have to give a positive finding in this case. Behavior, how treatment started with polydifferentiated synovial sarcoma after that? Have they
Ma'am,
started?
they have taken the blocks for
For genetic workup, ma'am. It is
Oh,
yet to, they have not done it. They have just taken, ma'am, yet to be done.
it's only the 4 round cell tumors, ma'am. Ewing's and round cell
ah,
sarcoma with EWSR1 fusion and CIC rearrange and sarcoma with Beaker alteration. So the
you tell us in the next meeting what was the
Okay, ma'am.
yes,
thing.
ma'am.
First,
Ah.
still with the morphology so well fit in with Ewing's, turned out to
Yes.
be a synovial. It's really brain-boggling case on.
No, it could be either synovial or it could be a
Yes.
CIC rearranged sarcoma, ma'am.
அது ஒரு
If anybody else who wants to comment and who wants to make suggestions.
a very new entity.
Yes, ma'am. So
We have
then,
to
then we can go on to the next presenter, ma'am. Dr. Yes, ma'am.
Dr.
Bhapati,
Bala,
ma'am. Yes, ma'am. Yes, ma'am.
my suggestion is we have come across cases like this. My
Yes.
suggestion is you should do this translocation study on thing to confirm the synovial sarcoma. And the
Yes,
second
ma'am.
one is I am voting for this is a weaker associated sarcoma because if you put weaker, no.
Yes, ma'am.
We have presented one case time. The weaker associated sarcomas. So this age group and all the markers in the CD99, TLE1, and even FLY1 is also positive. So more in favor of weaker associated sarcomas.
Ma'am, அப்போ B4ல வந்து WT1 will be
வரலாம் வரலாம் நான்
WT1
அந்த
will be
ஸ்லைட் பாருங்க அந்த WT1 வந்து அந்த அளவுக்கு உங்க CD99 அளவுக்கு அந்த WT1 அவ்வளவு இதுவா இல்லை அந்த TLE இது வரைக்கும் இல்லை நீங்க பீகார் இது வந்து போட்டீங்கன்னா பீகார் அசோசியேஷன்ல வரும் my suggestion.
Ma'am, but B-core can be also positive and poorly differentiated synovial sarcoma.
Yeah.
Appo then how do you finalize, ma'am?
That is suggested cytogenetic study. This is the only the X18 translocation. If it is negative, then only you can rule out the synovial sarcoma.
Oh, okay, ma'am.
Then
Okay,
that will go for B-car associated mutants.
Okay, ma'am. So cytogenetic study is the final thing to give a diagnosis. Yes, ma'am. Yes, ma'am. Taken, ma'am.
Thank you.
Yes, ma'am. Thank you so much, ma'am. Can we go on to the next presenter, Dr. Sumita? Dr. Sumita from MMC?
Yes, ma'am. Good evening, ma'am.
Please share your screen, ma'am.
Yes,
welcome. PG. Right here, PG. Dr. Sumita, you can start.
Yes, ma'am. Good evening, one and all. I am Dr. Sumita, final year PG from MMC. I thank my professor, Dr. Padmavati ma'am, for providing this opportunity. Coming to the case details, 60-year-old female came with growth in the right side of hard and soft palate, and CECT showed evidence of ill-defined heterogeneously enhancing mass lesion arising from the posterior aspect of the hard palate. Measuring 3.5 cross 2.6 cross 2 centimeter. Procedure done was videoscopy biopsy, and following by that, right inferior maxillectomy was done. Microscopy from videoscopy and biopsy, we received fragments of soft tissue, and in one fragment there was ulceration of the mucosa with underlying subepithelium showing a neoplasm. The neoplasm was predominantly arranged in trabeculae and mesh, with intervening stroma showing hyalinization. The cells are polygonal with having clear cytoplasm, and they having well-defined cell border and centrally placed round nucleus. Since this was a tumor arising in the oral cavity with clear cytoplasm, we have to rule out epithelial origin, and we should also think of minor salivary gland tumors. So we did myoepithelial markers also. We did pan-CK. Pan-CK showed diffuse strong positivity in more than 90% of the tumor cells, and CK7 showed diffuse strong positivity in more than 90% of the tumor cells, and P63 was positive in more than 90% of the tumor cells. Then for myoepithelial marker, we did calponin. Calponin was negative. Since calponin was negative, we ruled out myoepithelial origin. Then sometimes clear cell mucoepidermal carcinoma can also have clear cell component. So we in order to rule out that, we did mucin markers. Muc5AC was done and it was negative. And to confirm the grade of the tumor, it was histomorphologically it was low grade. So we did Ka67, it was 2%. And to rule out metastatic deposits from renal cell carcinoma, we did CD10 and it was negative. So with this, we came to the impression that possibility of hyalocene clear cell carcinoma of minor salivary gland to be considered. Now, points in favor of diagnosis are: this is an elderly female, and the histomorphology, the cells are arrangement of the cells is in nest, trabeculae, and cords, and the cell morphology is clear to eosinophilic cells with a clear cell border, with a prominent cell border, and polygonal with centrally placed round nucleus, and the nucleus is of low grade, and the stroma shows characteristic hyalinization. And coming to the markers, pan-CK, CK7 and P63 was positive, and Ka67 was only 2%. In clear cell squamous cell carcinoma, Ka67 will be high, and there will be focal keratinization and will be seen. So, and CK7 will be variable positivity will be seen in clear cell squamous cell carcinoma. So, we ruled out clear cell squamous cell carcinoma by this. Then calponin was negative. By this, we ruled out myoepithelial tumors, and Muc5AC was negative. By this, we ruled out mucoepidermal carcinoma, and CD10 was negative, and with this, we ruled out clear cell renal cell carcinoma. And from this, we came to the conclusion that possibility of hyalocene clear cell carcinoma of minor salivary gland to be considered. Then, following this, patient underwent right inferior maxillectomy. We received a specimen with the cross showing a mass measuring 3 × 2 × 2 centimeter over the hard palate. Cut surface was gray white and solid. And in microscopy, the first scanner view showed the epithelium with underlying subepithelium showing mucus glands with an unencapsulated circumscribed neoplasm arranged in lobules and nests, with a stroma showing lymphoid aggregates and lymphoid infiltrates. And here in the lower view, you can see the arrangement of cells in trabeculae, nests, and in pods, with the intervening stroma is densely hyalinized. In this picture, you can see the hyalinized stroma separating the nests and trabeculae of cells. Here, the cell morphology is clear. The cells are large polygonal. The cells are polygonal with a well-defined cell border and having clears to eosinophilic cytoplasm and centrally placed nucleus. And one node showed, only one node was removed, and this node showed metastatic carcinomatous deposits, and this image shows vascular invasion. Microscopy showed clear to eosinophilic cells arranged in nests, cords, and trabeculae. Nucleus is centrally placed and round to oval with dispersed chromatin, and stroma is densely hyalinized. IHC, pan-CK, CK7, and P63 was positive. Calponin, CD10, MUC5AC was negative, and Ka67 was 2%. Final impression we gave us based on histomorphology and immunoprofile, features favor hyalinizing clear cell carcinoma of minor salivary gland and PT3 N1MX. Hyalinizing clear cell carcinoma, coming to the discussion part. Presentation, it is a low-grade tumor and in most cases arises from the oral minor salivary glands, and slight female predilection is seen, and median age of diagnosis is 56 years, and it characteristically harbors a translocation involving EWSR1 and ATF1, and in WHO 5th edition, this translocation is considered as a desirable criteria, and this is a low-grade tumor with it is slow growing and it has good prognosis. Treatment is surgery, and no radiotherapy is needed. Gross, the tumor size ranges from 4 to 50 millimeter. It is a well circumscribed and unencapsulated neoplasm. Cut surface is white tan and solid. Histopathology, there will be nests, cords, and trabeculae of eosinophilic or clear cells. Stroma is densely hyalinized, basement membrane-like to desmoplastic or fibrocellular stroma. Squamous differentiation in mucocytes can be seen, and it may connect with overlying epithelium and show pegatoid pattern of spread, and perineural invasion is seen in 50% of the cases. In increased mitosis, marked atypia and necrosis are usually absent, and if it is seen, it indicates high-grade transformation. Immunohistochemistry, it is positive for epithelial markers CK7, CK19, CK14, CAM 5.2 and EMA, and it expresses P63, P40 and CK5/6, whereas myoepithelial markers such as S100, SMA, MSA, calpolin will be negative. And some express P16, but they lack transcriptionally active HPV. Coming to the differential diagnosis, first differential diagnosis is clear cell squamous cell carcinoma. Here there will be malignant squamous cells along with the clear cells, and focal keratinization will be seen, and nucleus will not be of much lower grade as we see in clear cell carcinoma, hyalinating clear cell carcinoma of minor salivary gland. And CK7 will be focal, variable positivity will be seen. Clear cell mucoepidermal carcinoma. Here there will be three components along with clear cells. Squamite cells, intermediate cell and mucous cells will be seen. And for mucous component, you can put mucous markers, MUC5AC will be positive. Coming to epithelial myoepithelial carcinoma, here there will be epithelial and myoepithelial component. The tubular structures will be seen, and in the tubular structures, they are bilayer tubular structures. And the luminal shows the ductal epithelial cells, and abdominal shows the clear cells, which are myoepithelial cells. And these myoepithelial cells will be positive for myoepithelial markers. Next one is myoepithelial carcinoma. It is an infiltrative neoplasm. Here, periphery, there will be hypercellular and central hypocellular area will be seen. And myoepithelials can be either spindle-shaped, plasmacytoid or clear cells. And the background will be myxoid chondroid changes will be seen. And it is positive for myoepithelial markers. Oncocytoma, here again clear cell change can be seen along with characteristic oncocytes. Oncocytes are large cells having abundant eosinophilic granular cytoplasm with centrally placed nucleus which is vesicular with prominent nucleoli. Metastatic renal cell carcinoma, clear cells will be seen, and with intervening stroma is vasculature will be seen in the intervening stroma, and they are positive for CD10 paxate. Take home message is this case is presented here for its rarity. It has to be differentiated from other clear cell tumors which can occur in this region because this has a good prognosis and it is a low grade tumor, and desirable criteria is EWSR1 ATF1 fusion. Thank you, ma'am.
Thank you, Dr. Sumita. How did you distinguish it from mucoepidermoid carcinoma?
There the characteristic along with the clear cells, actually intermediate cells will show clear cell morphology, ma'am. Along with that, other components will be seen. That intermediate cells, squamite cells, and mucous cells will be seen, ma'am. And mucin markers, MUC1, MUC4, MUC5AC will be positive in mucoepidermoid carcinoma.
Did you do the markers here, ma?
Yes, ma'am. We did MUC5AC alone. We did, ma'am. It was negative, ma'am.
Okay, ma. That any questions?
Can we see the histology once again? Can I see? First one.
This is a small biopsy which we received initially, ma'am. It shows an ulcerated mucosa with underlying subepithelium showing a neoplasm. The arrangement is in trabeculae and in pods with intervening stroma is hyalinized. The cell morphology, they are polygonal with well-defined cell border. They are having clear cytoplasm with centrally placed round nucleus. With the following markers, ma'am.
Yeah.
So it's a tumor of the minor salivary glands.
Yes, ma'am. Tumor of minor salivary gland, ma'am.
What are the other sites where this tumor can occur? Hyalinizing clear cell carcinoma.
Most common in the oral cavity, ma'am. Oral cavity in the tongue, buccal mucosa, it can occur, ma'am.
Okay, Dr. Sumita. Ma'am, any questions or we can...
Very little tricky tumor. Very little tricky tumor.
Clear cell morphology with low Ki67, and it's a tumor of the minor salivary glands. Yes, Dr. Sumita, thank you so much. Thank you, and thank you, Team MMC and Padmavati Madam. And can we go on to the next case, Dr. Emmanuel from Miyot Hospital?
Yes, ma'am. I'll just share my screen.
Yeah, please.
Is my screen visible, ma'am?
Yeah, please.
Yeah. So, good afternoon, everyone. My
No,
name
yes,
is.
yes. I can't see. We can't see your PowerPoint.
Oh, okay, ma'am. 1 second. Ma'am, it says host disabled participant screen sharing.
Okay. Uh, Give me a second.
Yes, ma'am. Now I can share, ma'am.
Okay. Yeah, your screen is visible. You can start.
Yes, ma'am.
Welcome.
Thank you. Thank you. So, good afternoon, everyone. My name is Dr. Emmanuel. I'm a registrar at New Hospitals. I'd like to thank my HOD, Dr. Deepthi Jain, for giving me this opportunity to present today. Today, I would like to present the case of a 78-year-old male patient from Mauritius who presented with the OPD with generalized weakness, dizziness, and breathlessness on exertion. Patient had given past history of atrial fibrillation, cataract surgery, and recent transfusion. On clinical examination, only mild hepatosplenomegaly was detected. Routine baseline lab investigations were done. The complete blood count showed a picture of pancytopenia, with the monocytopenia being the significant finding here. We did not see any atypical cells. Peripheral smear showed anemia, leukopenia, and mild thrombocytopenia, and a history of transfusion was also noted. The impression given was pancytopenia. Radiology was also done for this patient, which showed sclerotic changes in various areas such as the sternum, vertebrae, and pelvis. PET-CT highlighted low to moderate metabolic uptake in the sclerotic and interspersed lucent areas. LDH was normal, serum ferritin values were elevated, but RFT and LFT was normal. So, with all this in mind, we had a differential diagnosis of autoimmune disorders by infection, primary myelofibrosis, lymphoma, myelodysplastic syndrome, and myeloma. He initially presented to us with a strong suspicion for MDS at presentation. So we went ahead with flow cytometry, and independent immunophenotyping showed abnormal population of 6.67%, which was strongly positive for CD45, CD19. CD10 was dim to negative. This population of CD19 positive B cells showed restriction for kappa, and they were also heterogeneously positive for CD11C with intermediate CD25 and intermediate CD123. The myelomonocytic series showed normal site scatter gated at 38.5%. Myeloid blasts were present at 0.57% with normal levels of 34, 170, and HLA-DR. So the features that were suggestive of B-cell lymphoproliferative disorder, suggestive of hairy cell leukemia, and view of the intermediate CD25, intermediate CD123, dim CD10, and restriction for kappa light chain. So coming with this in mind, bone marrow aspirate and biopsy was done. The clinician hinted that it was a difficult bone marrow aspiration. The aspirate smears were dilute with occasional mature neutrophils and lymphocytes. Here I have highlighted lymphocyte where you can see that the cytoplasm is showing those cytoplasmic projection and gives the classical appearance of the hairy cell. Coming to the bone marrow biopsy, so the bone marrow aspirate we had reported as a dilute smear with mature neutrophils and lymphocytes, and we then went ahead to report the bone marrow biopsy. The bone marrow biopsy showed fragmented. It was a fragmented biopsy and linear course of bone marrow tissue with hypercellular spaces, and there was trilineage suppression and with occasional erythroid myeloid cells and lymphocytes were also seen. A reticulin stain highlighted increase in fibrosis in the bone marrow. Coming to the IHCs that were done, I'm sorry. The IHCs indicated CD20 to be diffusely positive, CD10 was positive, cyclin D1 was focally positive, CD3 highlighted the T lymphocytes, and BCL6 was also done, which turned out to be negative. The CD10 in hairy cell leukemia has been reported in around 16% of the population. These are two studies that I had come across in which they had reported that CD10 can be positive in hairy cell leukemia by Jasenowski TM and Chen YH et al. So for confirmation, we went ahead with IHCs for annexin and BRAF. Annexin was focally positive, and BRAF was negative IHC for this patient. Incidentally, serology patient was also found to have antibodies detected against PMSEL, suggestive of systemic sclerosis, Barth sclerosis associated overlap syndrome. So with this, with all our investigations now highlighting the findings of a possible hairy cell leukemia and an autoimmune disorder also underlying, we went ahead with molecular investigation as the final confirmation. MPN panel, JAK, CALR, and MPL mutations were negative, but a BRAF gene missense mutation was detected. It was in exon 6 of BRAF gene. So usually the BRAF gene missense mutation for hairy cell leukemia is usually in exon 15. In some cases that I had found, I reported exon 11, but for gene missense mutation in exon 6 has not been reported so far. Hairy cell leukemia, it arises from a late activated post-germinal centered memory B cells. It represents 2% of new leukemia and diagnosis of approximately 50 to 63% in men and 51 to 59 in women. BRAF V600 is the causal genetic event in the vast majority, but does not include all of them. Mutation constitutively activates BRAF by autophosphorylation of the protein and downstreams the signaling pathway, giving rise to increased survival and proliferation and promoting leukemic transformation. So coming to the differential diagnosis and how we ended up with giving it as a hairy cell leukemia, I will, for the lack of time, I will just mention the IHCs. By flow cytometry, C25, CD123 was positive. Immunohistochemistry highlighted the presence of annexin A1. We were also able to prove the presence of a BRAF mutation. We had also given monocytopenia was present in the peripheral smear, which was characteristic of hairy cell leukemia. The other differentials were splenic marginal zone lymphoma and diffuse red cell lymphoma. But for all this, there was no splenic involvement in the patient, and PET-CT also did not highlight any uptake. Now, coming to the follow-up of the patient, patient is currently undergoing cycle 4 of bendamustine-based chemotherapy, and he's on routine follow-up for systemic sclerosis. And the clinicians also informed us that he is doing well for now. Thank you.
இதை ஆன் பண்றது இந்த பட்டன்
Yes, thank you, Dr. Emmanuel.
Thank you.
That was a nice case. And any questions?
Excellent presentation, doctor.
Thank you.
My doubt, what about the ISC BRAF?
Ma'am, IHC BRAF was negative, ma'am, for us.
Yes, yes. That is why I am trying to insist that point, because these usually I thought the molecular studies, it's highly financially it's very difficult to make out that molecular study. So I thought, in spite of that, the ISC marker, the cost is less, no. So
Yes,
I thought BRAF ISC I tried. But the thing is, most of the time, the ISC BRAF is
Recalcified.
negative,
Yes,
but
ma'am.
the molecular study shows a positivity.
Yes,
Then
ma'am.
only I insisted, instead of going for ISC, even if it is negative, it should not rule out the BRAF mutation. So
Yes,
for
ma'am.
that, then I went through the literature and I found out there are so many studies shows the ISC marker will be negative, but the molecular study is positive.
Yes,
So
ma'am.
for LCH and hairy cell leukemia, wherever you are having this BRAF mutation, better to have the molecular study than going for ISC.
Yes, ma'am.
This is what I'm trying to say. Thank you. Actually, excellent case. It's a wonderful presentation.
Thank you, ma'am.
Thank you, Dr. Emmanuel. Thank you.
Thank you, ma'am. Thank you, ma'am. My pleasure.
Thank you, Team NIOT. And we go on to the final case of the day, Dr. Ashwin from Apollo Hospital.
Good afternoon, ma'am. Good afternoon, all. Am I audible?
Yeah, you're audible. Your screen is not visible.
1 second, ma'am. Is it visible now, ma'am?
Yeah. You can start.
Okay. Good afternoon, all.
Good afternoon.
So today I'm going to discuss 2 related cases related to the picture in the slide. Without much ado, I go to the case history. So the first case presented to us in the early part of this year, he was a 65-year-old gentleman with complaints of swelling in front of neck. There was no other complaints. And there was a family history of his younger brother had a right adrenalectomy in the year 2006, the reports of which were not available. So serologically, the calcitonin levels were high. Calcium and parathormone was normal. And ultrasound wise, there were nodules in both the lobes of the thyroid, and they categorized it as ThyRADS 5, and the parathyroids were normal. So with the clinical picture, looks like that of a medullary thyroid carcinoma. So this was the ultrasound a picture wherein the margins were all irregular and there were vascularity within both right and left lobe nodules, and it was all heteroechogenic. And I was not able to get the gross picture of the case, but the crux is that both the lobes had lesions varying in size from 5 centimeter to 0.5 centimeter, and they were all close to the inked external surface. So this was a microscopic picture of the lesion. So it was well demarcated from the normal thyroid parenchyma, and there was areas wherein the tumor encroaches upon the normal thyroid parenchyma in an infiltrative pattern, and there were like vague fascicular pattern, nested architecture, and areas of sheeting noted within the tumor cells. And on high power, the individual tumor cells were all like polygonal with a lot of cytoplasm with moderate eosinophilic granular quality, and the nuclei were either eccentrically placed or centrally placed with some stippling noted amongst them. And there is this tight nested pattern with some organoid vasculature going separating this nest. And these are spindled areas noted in the tumor. And there was conspicuous lymphatic vessel emboli noted. And one of the perithyroidal lymph node also showed metastatic deposit. And the Congo red stain showed this apple green birefringence. There are other areas that showed similar apple green birefringence. So with this morphological and the clinical picture, we were likely to give a diagnosis of medullary thyroid carcinoma. But we noted areas like this in the center of the lesion, wherein there were these follicles closely intermixed with this nested group of medullary thyroid carcinoma cells. So these are different looking areas of the similar thyroid follicular thyroid follicles that are closely intermixed with this nested component. This is one more area. So here there are foci wherein this thyroid, well-differentiated thyroid follicular lesion is forming a sheeting. It's like forming a mass, and it's maintaining a line of control with the medullary thyroid carcinoma. And one more area wherein this imaginary the follicular carcinoma is pushing this medullary thyroid carcinoma or vice versa. So there were mass forming within the lesion, within the same lesion. So, and moreover, the quality of the nuclei in the follicular areas were different from that of the medullary area seen towards the right lower corner of the screen. It was not stippled. There was some partial chromatin with some irregular nuclear membranes. And here also, if you notice, there is some partial chromatin clearing. And it is quite different from the adjacent medullary component. And look at the intermits, how they are closely intermixed with one another. So we went ahead with the immunohistochemistry. First is the cytokeratin, wherein the nested medullary component showed this light staining, which it usually does, whereas the well-differentiated component was like heavily staining for the cytokeratin, pan-cytokeratin. And this one is a vimentin stain, wherein the supporting stroma of the nested medullary thyroid carcinoma was highlighted. Few of the cells also showed positivity for vimentin, whereas the well-differentiated components were well highlighted here. The area wherein the medullary appeared fascicular took up individual cell vimentin staining. Next is a thyroglobulin stain. So here you see few areas are taking up the thyroglobulin stain, whereas there is some geographical areas missing the thyroglobulin stain. So at high power, these areas are matching with the area of the medullary thyroid carcinoma, and this one is like taking up the thyroglobulin. Similarly, if you do the thyroglobulin study, in the right side, the follicular areas were taking up, whereas the nested area and the sheeted area was not taking up. And the vice versa happened with the calcitonin. So the sheeted area was reactive to calcitonin, and the differentiated area was negative. So with this diagnosis, amidst medullary and follicular cell-derived thyroid carcinoma was arrived, and WHO states the essential criteria. The WHO has two essential criteria for this entity. One is being the medullary carcinoma, other is the follicular cell-derived carcinoma components intimately intermixed within the same lesion. And second one is the two components should be morphologically recognizable and identified immunohistochemistry as well. So these are the two essential criteria, and no other desirable criteria is needed to identify this entity. And one thing the WHO has cleared this time is that the follicular cell derived part should be a carcinoma. Earlier on, there was it can be either adenomatous also, but this time they had cleared the confusion that it should be a carcinomatous part. So the two terminologies that is there in the essential criteria, they intimately intermixed and same. So what it actually means, we need to just date back to Satter's classification of synchronous tumors, wherein he coins two terminology, collision tumor and combined tumor. The combined tumor is also called as composite tumors. The collision tumor, wherein there are two anatomically distinct tumors, either presenting at the synchronous time, or they are just intermingling between the tumor cells happening. Whereas combined tumor, there is intermixed tumor cells between two varied populations. And there are two types of composite. One is like they both have different origin. And second set is they have a same origin within which two invasive carcinomas takes place. It is to this subset, this mixed medullary and follicular cell derived thyroid carcinoma belong to. And the most interesting aspect about this entity is its histogenesis. There were a lot of theories to this entity. Few of them being stem cell theory, being ultimobranchial bodies being the starting cell with red proto-oncogene, following up which the two tumors arise within them. Next is a divergent differentiation, wherein one cell has a red proto-oncogene, does a divergent differentiation to the other. Field effect is one more component, wherein medullary carcinoma, through its tropic factors, produces a paracrine effect to the follicular cells, as a result of which follicular carcinoma arises. Next is a collision effect, like what we described earlier. Next is an hostage theory, wherein few entrapped cells become hyperplastic, then it can metastatize with hyperplastic entity or neoplastic entity. Now, this one, the hostage theory, the essential criteria is against it. So it can metastatize with, it cannot metastatize with hyperplasia. It needs to be called with benign entrapped follicles only, because the follicular component needs to be a carcinoma. And next question to answer is how much of each component is necessary. There is no clear-cut cutoff or recommendation on the amounts of each component required for the diagnosis, but there are few pitfalls we need to take care of. A few of the pitfalls morphologically are the entrapped benign follicles. So this happens only in the periphery, usually in single follicles, occasionally in clusters. And you should also remember about the follicular variant of medullary thyroid carcinoma and follicular carcinoma with neuroendocrine differentiation. So these are the morphological points we need to remember. And IHC wise, we need to remember that the tumor per se is going to produce a pressure effect on the adjacent follicles, thereby disrupting it and pouring out the thyroglobulin onto the medullary cells, C cells. So which thyroglobulin can show positive on these cells in the periphery, especially. And we should also remember there are certain subset of medullary thyroid carcinoma that are thyroglobulin sensitive also. So next one is focal expression of calcitonin and CA in otherwise follicular derived neoplasm. It's insufficient for a diagnosis of this entity. So is it necessary to categorize the follicular component in this entity? There is two school of thoughts about this question. It's better to categorize it as CAP tells us to do so. But the clinical behavior of this entity is more similar to that of a conventional medullary thyroid carcinoma. So while reporting this entity, we need to report two separate synoptic reporting for each of the entity with their characteristics, with their tumor characteristics. And TNM, we need to use the medullary carcinoma one. So behavior, 25% of lymph node and distant metastasis is noted. Surgery is a mainstay. Radioactive iodine is not going to help, as medullary thyroid won't respond unless there is elevation of serum thyroglobulin. We can try a hope of radioactive iodine, but it is relatively long-term poor prognosis compared to the well-differentiated follicular derived carcinoma. So now going back to the case history, the patient had an younger brother who had a right adrenalectomy. So the patient was evaluated for MEN2. So he was found to have MEN2 pathogenic mutation, following which he was evaluated for MEN2 components, which was negative for him. And his brother was also checked. He was also MEN2 pathogenic positivity. He had that mutation, same mutation, and he was hypertensive and there was mild swelling in front of the neck. And his metanephrines, parathormones, calcitonins were all elevated, and he had adrenal and thyroid nodules also. So we had planned to do a adrenalectomy followed by thyroidectomy in some 2 to 3 weeks gap. So in Feb mid, we received a adrenal specimen which had an 1.6 centimeter nodular growth with medullary expansion, showing these cells with amphophilia arranged in again nested pattern. So this was consistent with pheochromocytoma. And 2 weeks later, we received a parathyroid lesion, the weight of which was 147 milligrams, and it was less than 1 centimeter. And it showed a nice adenoma, parathyroid adenoma with monomorphic polyhedral cells making the tumor. So again, the thyroid had lesions in both right and left lobe, both appearing grayish white to slight yellowish. But this time the patient had lesions within the center of the thyroid, and it was not abutting the external linked surface. And this was the tumor in the thyroid. Again, the younger brother also had two components, one being the follicular component, another being the medullary nested component, which is delineated by the thyroglobulin and calcitonin stain. So this side is calcitonin positive, and the thyroglobulin stain was positive on the other side. So again, a diagnosis of MEN2A associated mixed medullary follicular cell derived carcinoma, parathyroid adenoma, and pheochromocytoma was made, and family was advised to undergo screening testing. It was found that the elder daughter of the younger brother carried same pathogenic single allele of the red proto-oncogene both the brothers had. So just a quick, just on the multiple endocrine neoplasia, MEN5 is the only tumor in this group to have a tumor suppressor gene to get deranged. The rest of all has something to do with the tumor proliferative genes. And one of the thing is, and MEN2 is divided into MEN2A, 2B, and familial medullary thyroid carcinoma. This is earlier called as MEN3, MEN2B. And there is a few clinico-pathological hallmarks for each of the MEN syndrome. For example, MEN1 is multicannular parathyroid disease is the hallmark. MEN2, parafollicular C-cell hyperplasia is the hallmark. MEN4, it is a uniglandular parathyroid disease is the hallmark. So RET per se, the most important thing this slide depicts is the genotype of the RET mutation. That is the most important thing to note, because genotype is equal to the phenotype of the patient. Genotype is equal to the aggressiveness of the tumor. So the most common is the 634 codon, where cysteine is replaced by arginine. This is the most common reported mutation. And why I say genotype is the most important thing is because of two interesting things this tumor hold. One is this being an autosomal dominant with penetrance of 100%. There is one entity of, there is one mutation wherein PA883T needs an homozygous setting for the penetrance to happen. And one more thing to notice, more the protein closer to the cell membrane is involved in the mutation, more its transforming ability to become a activated heterohexamer complex, thereby progressing the MAPK signaling pathway, thereby leading to proliferation and tumor thereon. So they have in fact stratified the risk based upon the genotype, and there is no low risk since penetrance is 100%. There is only highest, high, and moderate. Most important to note here, the genotype 918M, 918T is the most important. Most common cysteine codons fall under the risk of high risk. So as I was telling, the genotype and the penetrance level of 100%, there is always a scope of prophylactic thyroidectomy in patients with MEN2. That depends upon the genotype again, because the genotype is characteristically associated with the age of onset of MTC. So thereby we can time the thyroidectomy adequately. So it is risk level is triaged from A to D level. D is the worst level, wherein the thyroidectomy should be done first months of life, whereas A is okay to have at 5 to 10 or based upon the serum levels of calcitonin and thyroglobulin. So the take-home messages from this study is, so the association of mixed medullary follicular cell derived thyroid carcinoma and MEN2 syndrome, it is reported quite in the few of the articles also, and there is no minimum requirement for each of the component for this classification. Two things to remember in mind is same lesion and intermixed population. The prognosis is similar to medullary thyroid carcinoma. Genotype is everything. It means phenotype, it means aggressiveness. The hallmark of this entity is hyperplasia of the parafollicular cells. Remember 100% penetrance. So there is always a scope for prophylactic thyroidectomy, and genetic screening is always beneficial in these patients. Thank you. Thanks for the opportunity.
Thank you, Dr. Ashwin.
Thanks, ma'am.
What about the treatment of this the dual lesion?
Ma'am, predominantly they have a relatively poor prognosis compared to the well-derived the follicular carcinoma, ma'am. But what they treat is surgery is a mainstay. We cannot depend on the radioactive iodine. If at all, there either the medullary component is like thyroglobulin sensitive, or else there is the follicular derived cell is like metastatizing. Then there is other scopes, ma'am. Otherwise, the prognosis is comparatively bad only, ma'am. The metastatic rate of 25%, ma'am.
Like you said, his brother also had a dual lesion, the medullary and follicular.
Yes, ma'am. Yes. Yes,
What was
ma'am.
your criteria for diagnosing a follicular carcinoma in this case? Can we see there was a little
Ma'am, this the follicular area, the follicular even that was like what we see in a widely invasive follicular carcinoma. Though the nuclear area where the nuclear features were not like uh, completely seen like what we see in a follicular variant of papillary thyroid carcinoma, but the tumor per se had a widely invasive pattern of follicular areas, and it was closely intermixed with the medullary areas too. So that was the criteria we decided to call it, and those were area the thyroglobulin was also positive, ma'am.
because I had a little confusion regarding that follicular component where you showed. That's why I asked.
The follicular component, ma'am. 1 second, I'll just. So this is the follicular my screen is
No,
visible,
you're
ma'am?
not.
Here you go. No, ma'am?
Yeah, now, yeah.
1 second, ma'am. So if you see this area, this one was like a follicular area, ma'am. The follicular area of the well differentiated area, ma'am. And this one was like the medullary area.
Did you see any evidence of angioinvasion?
We did see, ma'am, that was a medullary component. The lymph node had a medullary component. So either of the component can metastatize, ma'am. So that is what.
Okay.
So we had a medullary component LVA.
Okay. When do they suggest a prophylactic thyroidectomy for these patients?
Ma'am, depends on when it is identified. Most of the patient is like it needs to be done at the before teenage, ma'am. So the reason being the onset of MTC in this kind of red proto-oncogene is early on. Like for example, the MTC age of onset for most of the genotypes that is involved are 5 or less than 5 years, the BCD levels. So it is better in the before teenage they need to undergo a thyroidectomy. But the this one the elder daughter of the younger brother is under the biochemical surveillance now. For she per se didn't have any other symptoms. So that's what, ma'am. The call of prophylactic thyroidectomy varies actually. This one is a American Thyroid Association risk stratification for prophylactic thyroidectomy, ma'am.
Okay, Dr. Ashwin, thank you for that wonderful case. Thank you, Team Apollo. And Madam, any questions? Okay, then then we'll close. Thank you, Dr. Ashwin. And so we come to the end of the city pathology meet with a host of cases from different institutions. And so we meet again in June. Thank you. Thank you all.